Hi, good morning. Actually, good afternoon to somebody who is not in California. So this is Erminia Massarelli. I am Associate Clinical Professor at City of Hope Comprehensive Cancer Center in Los Angeles area. And I'm also the thoracic chief here at my institution. So I would like to welcome you to our panel discussion about non-small cell lung cancer. And I will introduce you our discussants. So we have Dr. Shayma Kazmi.
Thank you, Dr. Massarelli. I'm Shayma Kazmi. I'm the Medical Director of Thoracic Oncology at Cancer Treatment Centers of America in Philadelphia.
Dr. Jason Porter.
Hi, good afternoon, good morning. I'm Jason Porter from West Cancer Center Research Institute, medical oncologist.
Dr. Keane.
Hi, my name is Keane. I'm a thoracic radiation oncologist at Massachusetts General Hospital in Boston. I'm very happy to be here with all of you today.
And Dr. Erin Gillaspie.
Hi, everyone. I'm Erin Gillaspie. I'm a thoracic surgeon at Vanderbilt University Medical Center. Great to be part of this today.
So these are our panel discussions. So we're going to start with the first case, and I'll share my slides. So the first case, here it is non-small cell lung cancer, incurable recurrent stage 3. So he is a 60-year-old man, never smoker. He had rare alcohol intake, past medical history of hypertension, hypercholesterolemia, diabetes type 2, anemia, asthma, and hypothyroidism, and was diagnosed with a 2-centimeter superior segment left lower lobe lesion with left hilum, left mediastinal, left supraclavicular lymph nodes involvement. Here you can see the PET-CT that shows you basically the left lower lobe nodule with the FDG avid mediastinal lymphadenopathy, and then on the right side you can see the left supraclavicular lymph nodes. So CT guided biopsy was done of the left lower lung mass, which showed lung adenocarcinoma, which was TTF1 positive. And so at this point, so his brain MRI did not show any metastasis. So at this point, I would like to start discussing what would be the first assessment and what would you recommend for this patient? And do you have any other questions about it? Do you want to, let's start with Dr. Porter.
Okay, so I can see here from the slide that we already have molecular testing done. There's a RET fusion, KIT 5B, and you said the brain MRI was negative?
Yes, so, you know, right, so the RET, yes, so we did have, I didn't say that because at the beginning, actually, we didn't know that, but molecular testing, yes, which was done subsequently, showed a RET fusion. And the rest of the molecular testing, Q1 was, he also had Iridia, SETD2, P53 mutation, tumor mutation burden was low, and MSI stable.
Okay, but with the negative MRI brain, and we're looking at stage 3B disease. I guess my questions would be, number one, what's his pulmonary function like?
It was well, he was not. He was assessed by the thoracic surgery. He was not considered to be a good surgical candidate.
Okay.
In addition to the multi-stage, you know, mediastinal lymph node involvement. So, yeah, he was assessed by thoracic surgery.
Right, and then Dr. Keane may be able to speak to my next question. Would be, what kind of considerations do you use for radiation or radiation assessment as far as his pulmonary function goes as well? And what are the things that you're looking at prior to radiating a patient? Oh, it looks like she had to step away for just a second. So that would have been my next question, not only for surgical resection consideration, but also for radiation consideration. And what's going to be the size of his windows for his radiation, how much good lung tissue is going to be covered. And she's back. Dr. King, I was just asking.
I'm so sorry about that.
That's okay. It's not a surgical candidate based on the surgeon's review. I was asking about considerations with pulmonary functions and the potential radiation window sizes and how much good tissue is going to be radiated, and what your concerns for PFTs would be for this patient.
Yeah, so I think in general, whenever we have a very advanced extent of nodal disease here, extending from the left supraclavicular lobe, far down into like the lower aspect of the left hilum, we certainly do get concerned. And, as we've seen from the dose escalation trials in radiation, like with RTOG 0617, normal tissue toxicity is really important, and that can drive how patients do. In terms of absolute PFT cutoffs, we don't have them. Certainly if someone had, interstitial lung disease or something where they're already on a significant amount of oxygen, you do worry about their ability to tolerate. This is an instance where certainly using more advanced techniques like VMAT and IMRT is very important for sparing not just the lung, but the heart. And also really making sure that your mediastinal staging is as extensive as possible so that you're fully treating disease and not doing elective coverage of nodal stations that don't need to be treated.
Okay, so anybody else wants to add any other inputs? So would you treat him overall with chemoradiation therapy, for example? So the option at this point, I think, are chemoradiation therapy versus like an approach like induction. However, this patient was not considered a surgical candidate. So my vote would be either chemoradiation therapy, if of course his lung capacity is adequate. This patient had actually performance status of 1, never smoker. So, he didn't have COPD, he did have history of asthma. However, I think he could have been a good candidate for chemoradiation therapy. But other option, like Dr. Kazmi or Gillaspie, do you want to add anything?
Thank you. I think I want to clarify. So he presented initially with a stage 3B disease, which does have a potential of cure with chemoradiation therapy. And we do need to talk about, of course, specific clinical trial. We talked about adjuvant durvalumab for a year after a significantly lowered progression-free survival. Of course, I'll defer to Dr. Keane in terms of the potential pneumonitis toxicity, though there was not any significant worsening of pneumonitis in those patients. We always worry about IOs, especially in terms of pneumonitis, especially followed by radiation therapy. But I think the differences were 25% placebo group and 30% in the durva group, which did not translate to any worsening in the grade 3-4 pneumonitis. It's interesting that, of course, the genomic testing in this case was done afterwards. I think there's a huge variability on when we do genomic testing in early stage non-small cell lung cancer patients versus late, especially in the advent of adjuvant osimertinib and the ADAURA trial. We're all at least doing EGFR testing in early stage patients. Perhaps it should be a broader NGS. That's a separate discussion. But as far as the red fusion information with drugs like selpercatinib and pralsetinib, they're more have data in the second line setting, and they also have first line data in metastatic setting. So of course was not an option for him when he presented as a stage 3B patient, but certainly when he relapsed and had recurrent disease, we can talk about red fusion drugs as well.
It does raise an interesting question, as you said, in terms of what the next steps are for these patients, particularly for a never smoker. And even though he doesn't have stage 4 disease, getting molecular testing in these patients is really important in terms of, even if they do get chemoradiation, should they get immunotherapy? If they have a targetable mutation, a lot of people would argue no, given the potential toxicity. So I think this is certainly a situation where if his performance status was borderline for chemoradiation at all, you'd really want to have that molecular testing to have sort of the full breadth of options to explore.
Yes, I agree. So in this case, this is a case is a few years ago, he was diagnosed. So we didn't have it. So, but definitely as of today, at least in my institution, we're doing NGS on all the patients, also candidate for chemoradiation therapy. So
just to add on one quick thing too, Dr. Keane mentioned something really important, and that is understanding the full extent of disease. There's a lot of ways to get biopsies, and it's really important to think about the implications of treatment when you're planning that. For this patient, I actually would not have done a CT guided biopsy. I would have recommended navigational bronchoscopy with sampling of the mediastinal lymph nodes. You could absolutely confirm in one setting the true extent of disease, especially if you live in parts of the country where there's a high incidence of things like histoplasmosis, which can certainly be PET avid and incorrectly stage a patient. And so always really think about trying to get as much bang for your buck with one procedure if you can.
This is a very good observation. So we can probably move forward. And so this patient was subsequently treated with concurrent radiation therapy and with carboplatin and paclitaxel weekly as concurrent regimen. He then went on to receive durvalumab. So we, as of today, standard of care for a patient with incurable stage 3 non-small cell lung cancer after chemoradiation therapy, there is recommendation according to the results from the Pacific trial to proceed with durvalumab for a total of 1 year as maintenance therapy after concurrent chemoradiation therapy. Now, in this particular case, the patient, after one dose of durvalumab, developed what was defined as radiation-induced pneumonitis. Now, my question to you, I thought actually that after one dose of durvalumab it's unusual to see an immune-related side effect. However, it could still be possible. According to the Pacific data on toxicity and pneumonitis, actually there was not significant increase in the grade 3 or 4 pneumonitis in the two different groups. So the group that was on placebo versus durvalumab. So probably Dr. Keane is the one I would start with.
Yeah, so as Dr. Kazmi mentioned, there isn't a significant difference in grade 3 or 4 pneumonitis. The rates of any grade pneumonitis were about a third. That obviously encompasses radiographic changes as well as patients potentially who are on steroids. I think it's always a question that we struggle with in terms of patients who develop pneumonitis, after they've received radiation and have also received durvalumab. Sometimes looking at the prior radiation fields can be helpful in determining, what is the extent of the radiographic changes and do they fit with the radiation fields. For example, in this patient, a lot of those changes on the right side are a little bit more than you'd expect, but it's tough to know without seeing the radiation plan. I think ultimately, if someone has symptomatic pneumonitis in a scan that looks like this, what caused it in the short term is less important than treating it with steroids, but obviously it does influence how you manage down the line and whether they would be rechallenged, with immunotherapy. And obviously that's something I would defer to you all on.
Okay. Any other comments about, so of course we all agree that the treatment for pneumonitis is steroids. Now, independently of if it's immune-related or radiation-induced. And this patient was treated with steroids. He had a long course of hospitalization. He was oxygen dependent, but he was discharged. That was the first time I saw him in clinic, actually. And so at that point, basically, I advise, of course, not to re-challenge him with durvalumab. Now, with patients with a significant grade pneumonitis, I usually don't re-challenge them with immunotherapy. So I would like to ask all of you, what's your practice?
So I'll just ask, was this patient hospitalized?
Yes.
Okay, so I mean, of course, the fine-tuned grading of these pneumonitis is super important because that's how we define these in clinical trials. And grade 1 being asymptomatic, visualized on imaging, grade 2 being hypoxic, yet not necessarily needing admission. And then you have the grade 3 and 4, I think, vented and really critically ill. So the grade 2s I would consider re-challenging, but you're absolutely right. If somebody needed hospitalization and really didn't get good control with high dose, 2 milligram per kilogram prednisone right away, then that's someone to be extremely cautious with, though perhaps the timing of the radiation and the IO didn't play well in this patient because it was so early on. Perhaps down the line, a year or two later, if they do recur, I never say never. So I think it's always a risk-benefit discussion at that point. If they've burned through all the other options, I mean, it's always there. But that's my opinion.
Right. Okay. So if there is no other comments, I think we can go. I don't think we have any other slides on this case. So just to let you know, what happened was that he was placed on observation, and 2 years later, the CT scan showed, so it was of course undergoing CT scans every 3 months, and showed mediastinal lymph nodes that were biopsy positive, lung adenocarcinoma. He was basically considered an incurable stage 3B again. So he had the relapse in the mediastinal lymph nodes, and he could not be surgically resected. Of course, after the reaction with radiation therapy, radiation was not a good option for him. So at that time, of course, he had molecular testing, which showed the red fusion. So it was a red fuse with KIF 5B, and then he had ARIDIA 1, ARDI 2, and then he had SETTD 2, TP53. Tumor mutation burden was low, and MSI was stable. His PD-L1 was low. So what would you have done with first line, considering also about the toxicity that he had with potentially, we don't know if it was immune related, but definitely radiation-induced pneumonitis. Dr. Gillaspie, do you want to start?
So I'm a thoracic surgeon, so I don't really give first or second line advanced stage. So I will.
Would you have even considering a patient with, for example, a stage 3B, a salvage surgery? I mean, that's
No, not after this degree of pneumonitis and this degree of radiation and things. I think it would be very, very difficult to clear the disease. And really, when thinking about surgery, one of the kind of really overarching factors that we always have to consider is, one, can the patient tolerate it, but two, can we actually safely resect all of the disease? And it just, based on the patient's initial kind of presenting burden of disease, the location of the recurrence, and some of the complicating factors from index treatments, I would say this would not be an ideal circumstance to try and clear disease with aggressive intrathoracic control.
Good. Yeah. So, and then Dr. Keane, so basically just one question about, when do you ever consider to re-radiate a patient who was treated with chemoradiation therapy? What's the threshold time, and also, of course, how much radiation they received before?
So I think certainly with this patient, that his experience has sort of already precluded him. I think one of the things we struggle with is if someone has recurred in field after a definitive dose of radiation with chemotherapy, we really have to ask ourselves, is adding on another definitive course of radiation going to actually provide a meaningful cure, or is there just too high a risk of toxicity? And really, I think in 99 cases out of 100, it's the latter, where, if the first course was not sufficient, we worry that the second just carries a significant risk, and also, has a low likelihood. If there's an out of field failure that's maybe from a new primary or nearby, that's obviously a different discussion, but that is a more rare instance.
And Dr. Porter, so would you have been, so now that this patient has a red fused non-small cell lung cancer, so would you have had problems thinking that, using a red specific inhibitor with the risk of pneumonitis, for example, a side effect?
I don't, it's one question I do have, was he ever able to be weaned off of his oxygen, or is he still oxygen?
Yes. So so this is the detail. So basically after about 2 months, he was able to come off oxygen.
Right.
And actually at the time he relapsed, he was in very good, he had a very good performance status. So it was PS0.
So, as Dr. Kazmi mentioned earlier, we don't know if this was IO related or if it's timing related to the radiation. And so if he's been able to come off of oxygen, then I would kind of give him the benefit of the doubt, especially knowing how effective the RET inhibitors are. And I probably would go ahead and treat him with a RET inhibitor, carefully so, obviously, and watching him really closely. probably get some PFTs and understand his lung physiology before I start. But I probably would definitely be considering that in him, especially since he's not a candidate for any other curative intent maneuver.
Right. Dr. Kazmi, do you agree? I see that you were nodding.
I do.
Okay. So that's, so basically he was placed on sulfatinib and actually remains, he had an amazing response and it continues. It's been more than 6 months now. So that's a happy ending so far. So if okay with you, I will go to the second case. So this is a metastatic left lung squamous cell carcinoma to bones. So this is a 62-year-old man with history of hypertension, hiatal hernia. He's a never smoker, and he presented with dry cough to PCP and was diagnosed with reflux. Several months later, experienced an episode of hemoptysis. I went to the emergency room, chest X-ray showed a large 5-centimeter left intrahilar mass, and the CT chest with contrast showed a 7.4 times 5.2 times 5.7 centimeter left lower mass extending to involve the left hilum. So the MRI was negative of the brain. And here you can see the PET. So the PET CT showed this highly FDG avid left lower lobe mass with, well, I couldn't show you the, let me see if I have. Okay, I don't have the involvement of the mediastinal lymph node, the hilar lymph nodes, but he was found to have what we define probably like oligometastatic disease. So it was a T8 vertebral body here, and then you can see it here, and he also had a left pelvic lesion. So he underwent palliative radiation therapy and NGS. So the CT guided biopsy showed squamous cell carcinoma. So keep in mind this is a never smoker, and showed EGFR exon 21 L858R sensitizing mutation. His PDL1 of note was 90%. So, so this is a squamous cell carcinoma, one of those few rare squamous cell carcinoma which we see here in South California, who are never smoker and present with EGFR mutation. Very interesting for this case was the PDL1 high expression, 90%. So I'm asking, okay, we have two important questions here. One is treatment of oligometastatic non-small cell lung cancer. The second is treatment, sequential of treatment with EGFR TKI versus immunotherapy in these patients. So let's start with oligometastatic disease. Anybody wants to start to comment? Okay, Dr. Gillaspie.
Yeah, I'd be happy to make a couple comments. I find oligometastatic disease just fascinating overall, because I think there are some that can be very much helped with aggressive local control, and I think some that we really don't help at all, and we're still really working to define clearly which patients fall into which category. I think a few kind of overarching themes that I think about when considering treatment for patients with oligometastatic disease is one, and something I've already mentioned, is ability to completely resect the disease with aggressive intrathoracic control and control of the oligometastatic sites. The second is location. So I think we do know that some locations are better than others. Brain seems to be a site where aggressive, radiation control, surgical control combined with a systemic approach can have better outcomes. Adrenal as well. There are some studies that suggest that maybe adrenal is maybe even more tantamount to a lymph node met. Overall burden of disease is super important. So is it, hilar lymph nodes plus mediastinal lymph nodes plus metastatic site and a primary, or is it just the primary and a metastatic site? The more sites you add, even if they're lymph nodes, confer a worse outcome. And then of course, finally, a patient's ability to tolerate a really aggressive multimodal treatment regimen, because one thing alone is not going to be enough. You're going to need systemic. And if you're going down an aggressive local control route, the patient's going to need to be able to tolerate all the components of it together.
Okay. Dr. Porter, do you want to add anything?
Well, calling this oligometastatic disease, like Dr. Gill, I'm fascinated by this case because, you know, with the ADORA data and this EGFR mutation, even though it's in a squamous cell patient or a patient with squamous cell carcinoma, there's a lot that can be done for this patient because of the, you know, the bone metastases. It sounds like they were radiated. After those are radiated, I would go and look closely at that mediastinum. As long as it's negative, take that lung mass out, and then either give this patient adjuvant chemo or adjuvant chemo followed by osimertinib. And I think that is a lot, but as long as the patient could tolerate it, that would be, I think, a really good way to approach this case. That's what I would do.
I think one question as we think about the oligometastatic patients is how much control do we get of these sites? So it's important in terms of like what dose of radiation they actually gave, and that area that looks sort of like a lymph node, like were they able to give it a definitive dose? Because it is, as everyone said, like a challenging thing. If do you put them through a surgery or do you start them on a very effective systemic therapy with osimertinib and then see, you know, how their next scans look? Because it's also like, is this the tip of the iceberg or is this truly all that's there?
Mm. Yeah.
Yes.
So I would disagree with Dr. Porter. I think this is quite a bit of a burden of disease to sort of dissect and resect, although time is my best friend when I'm not sure. So what I agree with is, of course, palliative radiation to reduce skeletal complications, perfectly appropriate for pain management. But squamous or not, as Dr. Massarelli mentioned, NCCN recommends, you know, genomic testing for squam patients that are never smokers, small samples, they could have mixed disease, and really anybody. I tend to do it on most anybody looking for other potential drivers of mutations. And so in this case, I would opt for systemic treatment with osimertinib first. If there is some time where disease is maintained, responses, nothing new flares up, then you can always come back and reevaluate whether aggressive therapy is warranted. And and I will add one more thing about the PDL. We certainly know that, of course, in patients who have driver mutations such as EGFR and ALK, single agent IO therapy has not been effective and can worsen immune-related complications such as pneumonitis that maybe has to do with the TKI in close proximity to the IO therapy. But we don't know whether combination chemo immunotherapy Empower 150 looked at that, and there was a small number of patients with EGFR and ALK mutations with a combination of platinum, taxane, it was Bev and Atezo, and they seem to do okay. But
so let me tell you about, you know, this is a very unusual case. So this is not the usual, you know, EGFR mutant with high PD-L1. I completely agree that I usually don't pay attention that much to the PD-L1 level of EGFR mutant, because we know that immunotherapy, especially up front in the EGFR mutant, do not work. However, so this patient, we don't know, I think there might be something specific about squamous cell carcinomas that have EGFR mutations. But anyway, this patient was treated with, at that time, osimertinib was not approved yet. So he was treated with erlotinib. And he actually had just stable disease, didn't have a significant response, and then he started growing. And so we had an open trial with nivolumab plus dasatinib at that time. And due to his, he really didn't want chemotherapy. So I said, okay, we can try. And actually he had an impressive response because probably of the combination, you know, with dasatinib. And so but I would say, you know, I agree with you that EGFR mutants usually don't respond to immuno alone, but eventually I think novel combinations might be to be explored in patients who do not respond to EGFR TKI, plus or minus chemotherapy. So this patient actually remains, he had to come off trial, you know, after 2 years because of the trial completed, and he actually remains on nivolumab. Now it's been 4 years. So you see this unusual, so that's why I want to stress that it's very important to do molecular testing. It's very important to individualize the care for each patient. I'm sure that if we gave him chemotherapy with immuno, he would have responded anyway. But in patients who, you know, might not want chemotherapy or have problems, for example, performance status or other issues, of course, clinical trial is always our preferential enrollment. But so as a standard of care, I have to tell you, I would have probably done chemo plus immuno after EGFR TKI, and especially I like the combination with VEGF inhibitors. So for a patient who is very good performance status, and he has, for example, squamous EGFR mutant after TKI failure, I would definitely, I mean, we could consider, for example, carbotaxol plus Bev and Tizo. That's a good combination, or other VEGF containing. However, you know, this is a squamous, so it's a central mass. So there is actually some contraindication with using VEGF therapy in squamous cell carcinoma. So for the dasatinib, it was a clinical trial, so it was kind of a little bit but it was not an exclusion criteria. But I would be very careful, you know, with such a large mass, for example, going on Avastin, for example. I mean, so, you know, medical oncology is difficult because of this. You know, we have to pay attention about everything. The other thing is important. So this patient had an episode of hemoptysis. So at the beginning, I didn't tell you that this patient actually did have also palliative radiation therapy to the lung mass. I forgot to tell you because of the hemoptysis episodes. So that's another important addition. And I think, let's see if there is any questions. Yes. Okay, so we can probably go to the questions. We had two questions. One is, what is the recommendation for a 2 centimeter lung lesion with no nodes involvement and no metastasis? And no metastasis. So 2 centimeter lung lesion with no nodes involvement and no metastasis.
That sounds like a very early stage lung cancer.
Dr.
Coming over to
Gillaspie
Dr.
there.
Gillaspie, and I think there was something that precluded surgery. They could come see me. But,
Or SBRT, probably.
Needs PFTs. I don't know if perhaps this person was trying to get on the fact that, you know, there is some trials that have kind of wrapped up looking at 2 centimeters and kind of as a cutoff, or whether or not to do a lobectomy versus a sublobar resection. If that was the place that person was hoping to touch on, I can just say very, very briefly, data is still cooking. There's a lot of single institutional studies and the lung cancer group trial back from 1995 that showed that lobectomy should be the standard of care. That has remained the standard of care for patients who can't tolerate that. Then I think sublobar versus SBRT are great options for patients, but stay tuned for GGOs and for smaller nodules. It may be that segmentectomy could become the standard of care in the future. Always, always, always lymphadenectomy, aggressive.
We have another question that we have to close. So if a patient has progression on osimertinib that has a MET exon 14 skipping mutation, would you add capmatinib to osimertinib?
So there is the new bispecific antibody, amivantamab, that is designed specifically for the EGFR patient that progresses on a TKI, has a MET mutation. Until that's available everywhere, I think absolutely adding capmatinib to the OC is reasonable.
We have to close, unfortunately, but so thank you to all our panelists for your participation, to the attendees for tuning in. We had a great discussion, and we will now have a quick break. You can use this time to continue, you know, earning points toward our Engage and Win giveaway by connect with industry representatives in the exhibitor hall or connecting with colleagues in the networking lounge. We will meet back in a general session to hear updates on hematological malignancies. We will not have time for any other question, and you know, we'll try to respond online. Thank you.
Thank you.